What do we know about death pathways related to photodynamic therapy? An important consideration is selectivity. The carbon dioxide laser can kill any cell in its path, but there's no selectivity involved. While most photosensitizers accumulate in certain host organs such as liver, spleen, and kidney, these are normally protected from light. What is important is that the useful photosensitizers tend not to accumulate in other tissues in the vicinity of tumors in such sites as lung, skin, brain, muscle, and bone. A variety of death pathways have been observed after photodamage. Photodynamic therapy can also shut down the blood supply to the tumor. This is not something that can be seen in cell culture, but it's an important element of successful tumor eradication. We will not know whether or not a photosensitizer can affect blood flow unless this is tried in an appropriate animal model. Sometimes interrupting the blood flow alone can be sufficient to produce a significant anti-tumor effect. There can also be an immune response to the remaining tumor cells after photodynamic therapy. This illustrates the requirements. We need oxygen, we need light, and we need a photosensitizer to produce a photokilling effect. Different photosensitizers can localize in different cellular sites. Some can find their way to several different sites. As we will see, the formulation procedure can also affect localization. Major sites of localization are shown here: lysosomes, the ER, the plasma membrane, and mitochondria. This is a summary of what we know about photodynamic therapy. Photodamage to the endoplasmic reticulum, lysosomes, or mitochondria can initiate apoptosis. This is an irreversible route to cell death, does not involve inflammation, and is a common result of photodynamic therapy. Autophagy is usually cytoprotective. It protects the cells from the photodamage by engulfing these damaged organelles before they can initiate apoptosis. But it does require that we have intact lysosomes for completion of autophagy. So photodamage to lysosomes is going to cause an inhibition of autophagy. ER photodamage can also lead to something called paraptosis, a death pathway which we will discuss later. This is totally independent of apoptosis. Apoptosis is defined as a PDT effect first noticed by Nancy Olenek in 1999. People have been using photodynamic therapy for many years without any idea of how it worked. Damage to mitochondria, lysosomes, or the ER can initiate this death pathway. Apoptosis is a strongly conserved death pathway that plays a role in embryonic development and other biologic functions. The net result is a disintegration of the cell into fragments that can be engulfed and digested by macrophages with no release of DNA into the environment and no release of inflammatory products. Autophagy is a different process. This acts to isolate subcellular organelles from damaged cells into membrane-bound particles that fuse with lysosomes. Lysosomal enzymes then digest these organelles for recycling. This is generally a cytoprotective effect in the context of photodynamic therapy, protecting the cells from death. This slide shows some examples of both apoptosis and autophagy. To the left is a dose response curve for effects of photodynamic therapy directed at mitochondria. In the wild-type cells, you notice a shoulder on the dose response curve, showing that autophagy can partially protect cells from death. What is likely happening is that damaged mitochondria are being engulfed and digested before they can release cytochrome C and initiate apoptosis. Eventually, the number of mitochondria being damaged exceeds the ability of autophagy to protect, and the cells begin to die. If we silence either of two genes associated with autophagy, ATG5 or ATG7, autophagy is prevented, and the death curve proceeds with no interruptions. There's a different result shown on the right when lysosomes are the target. Since lysosomes are needed for autophagy, the process is impaired and we see no shoulder on the dose-response curve. Silencing ATG5 therefore has no effect. But to our surprise, we found that silencing another autophagy-associated protein, ATG7, greatly impaired the PDT effect. We found that this protein serves another function. Photodamage to lysosomes can result in factors that promote apoptosis. In the absence of ATG5, these factors are not released. This function of ATG5 is not related to its role in the process of autophagy. The photosensor hypericin only targets the ER. It's highly selective for just the ER. Studies with fluorescent probes show no affinity of hypericin for mitochondria, but a good correspondence of its fluorescence with the ER. Photokilling results in a dose-response curve with no shoulder, indicating that autophagy cannot protect cells from the effects of ER damage. We will see later that ER damage can result in another pathway that does not involve apoptosis. At this point, we'll turn to a discussion of effects of altering the targets of photodynamic therapy using a combination of two different photosensitizing agents. In 1996, it was reported that a combination of two photosensitizers could eradicate large tumors in rats. Up until then, it had been reported that the penetration of light into tissues limited photokilling to a depth of no more than 5 millimeters. But the combination of two photosensitizers, BPD and ETNBS, resulted in eradication of 1 centimeter deep tumors in the rat. BPD was known to target mitochondria and the ER, while we now know that ETNBS is specific for lysosomes, but it was also known that this could shut down the tumor vasculature. So the theory was that a PDT dose of ETNBS that had only a slight effect, combined with an effect on the vasculature, could cause a net increase in photodynamic efficacy. Here we see that in the dark, nothing happened. ETNBS alone had a slight effect on tumor weight. BPD had a greater effect on tumor weight. But if we combined the two, the tumors, many of them were obliterated. However, the dosing was important. ETNBS had to come before BPD. If it did not, the effect was only additive. So there was something about this procedure that required that the effect of ETNBS occur before the effect of BPD. But nonetheless, we see that we get a very profound effect with this combination, the effects of which were finally explained in the year 2016. This image shows that the combination of BPD plus another agent, this time we used NPE6, which also targets the vasculature and lysosomes, but this had a synergistic effect in cell culture where there's no vasculature to be shut down. This result indicated that it was the site of subcellular photodamage that was the important factor here, not any antivascular effects. What appears to be happening is a series of events where lysosomal photodamage is sufficient to release calcium into the cytoplasm. Dr. Simone in Switzerland had shown that this activated the enzyme calpain, a protease. Activated calpain could then cleave one of the autophagy-associated proteins called ATG5 to a fragment. And when this fragment migrated to mitochondria, this greatly promoted apoptosis. The net result was that lysosomal photodamage primed mitochondria for an apoptotic response to photodamage from BPD. The reason that lysosomal photodamage needed to become first was that this truncated ATG fragment has a very short half-life and the effect rapidly disappears. So mitochondrial photodamage needs to come within a few minutes after the TATG5 is formed. Otherwise, the effect is lost. This image shows that there is a small amount of TATG formed after photodynamic therapy involving NPE6. If we look at the dose-response curve of the combination versus BPD alone, we can see that the protective effect of autophagy is lost. While there may be some impaired autophagy, I suspect that there is so much more apoptosis that autophagy can't deal with all of the damaged mitochondria. And we get, therefore, a much greater photokilling effect. This in vitro study shows what happens if we delete the ATG5 gene. Here we have wild type cells, BPD causing a mild decrease in viability, NPE6 similarly very small decrease in viability. If we add the two together, we get a highly synergistic effect. Now, if we delete the ATG5 gene, which is responsible for the synergism, we get the same, essentially the same effects of the drugs alone, but we combine the two, it's no more than additive. So we clearly need the ATG5 gene to see this effect, this additive, this synergistic effect of lysosomal plus mitochondrial photodamage. This image shows what happens if we inhibit the activity of calpain by the antagonist termed ALLN. Here we then get only an additive effect when we combine the two photosensitizers. While we have been using clonogenic studies throughout this work to determine the effect of PDT on colony counts, it's not necessary to have an automatic colony counter to see the effect. We can see the extent of photokilling by just looking at the plates. Here we have control cells on the left, mitochondrial photodamage on the right, and mitochondrial plus lysosomal photodamage on the far right. At this point, I'm going to introduce a new concept, changing the subcellular PDT target by modifying the formulation. BPD, which we use to photosensitize the ER in mitochondria, is not soluble in water, so it's formulated in liposomes. These are small lipid spheres with a BPD inside. This permits a poorly soluble material to be prepared for injection. But once inside the cells, this BPD formulation called Visiodine releases the BPD where it migrates to the mitochondria and the ER. But if we first attach the BPD molecule to a very large lipid, something else happens. The lipid BPD construct merges with an endosome and delivers the BPD to a lysosome. So if we mix these two formulations, we can target mitochondria, ER, and lysosomes with BPD, and we don't need to use a two-sensitizer combination and two wavelengths of light. This makes the overall process much simpler, and we still get the combination that promotes photokilling. In this slide, we also note that ER damage can result in a new form of death, which I will discuss in a moment. But here we see the release of calcium, calpain activation, cleavage of ATG5 to this fragment, which promotes photodynamic efficacy. Looking now in 3D culture, where we grow an ovarian carcinoma in small spheres in a matrigel environment, we show that liposomal BPD can kill 50% of a cell population with a 5 joule per square centimeter light dose. At a 2.5 joule per centimeter dose, there's barely detectable damage. Using the BPD formulation that targets lysosomes, we see very poor efficacy, even with a 60 joule per square centimeter light dose having little effect. It's not clear why for 3D culture these cells respond so poorly to lysosomal photodamage, but there it is. However, when we combine these two formulations, we see a greatly enhanced photokilling effect. A 2.5 joule per square centimeter light dose is sufficient to kill greater than 95% of the cells. Here we see the free and the anchored BPD and the two together with a greatly enhanced efficacy. To sum up, by modifying the formulation, we can use the same agent to kill mitochondria, ER, and lysosomes. But what about the ER? It turns out that this can bring about photokilling of tumor cells by a process that does not involve apoptosis and be used with tumor cells that have an impaired apoptotic pathway. This new process is termed paraptosis and involves an effect on the ER that fills the cytoplasm with vacuoles and eventually results in cell death. This is not apoptosis, where the cell is decomposed into fragments. It's not autophagy, where a cytoprotective effect occurs. It's not necrosis, where the membrane is damaged, but a totally different effect that can kill cells with an impaired apoptotic program. This shows the morphology of apoptosis at the top, where we see fragmentation of DNA and fragmentations of cells, where the cell is eventually broken completely into these fragments that are engulfed by nearby cells. With paraptosis, the entire cytoplasm fills with vacuoles, but there is no fragmentation of the DNA, and the nucleus remains intact. In this image, we use a probe provided by Enzo that labels autophagic vacuoles to show that the vacuoles formed during paraptosis are not the same as the vacuoles formed during autophagy. We induce autophagy here with chloroquine and rapamycin, paraptosis with BPD and light. And the vacuoles formed with the autophagic procedure are clearly labeled with this green fluorescent probe, where we see the vacuoles formed during paraptosis are not. So these are not autophagic vacuoles. This slide shows how paraptosis develops after ER photodamage. First, a ring of vacuoles forms around the nucleus. This gradually fills the entire cytoplasm, and the cells become quite chaotic. And eventually the cytoplasm is lost, and bare nuclei are floating in the media. These are clearly non-viable cells. This shows that paraptosis is a common response to photodynamic therapy, but people tend to miss this because most investigators don't examine their cells by microscopy. Paraptosis will form after treatment with any photosensitizer that targets the EL. This includes meta-THPC, photoferrin, HPPH, a new drug being developed by Dr. Pandey at Roswell Park, but not agents that don't affect the ER, like NPE6 or ETNBS and some others. These cells do not initiate apoptosis since no ER photodamage is involved. Here we see the difference between autophagic vacuoles, which have a double membrane and are filled with material being digested, and paraptosis, where the interior is relatively empty and there is only a single membrane with nothing inside. At very high light doses, ER proteins become cross-linked, and paraptosis is not seen. Cells then tend to die by either apoptosis or necrosis. So here we see phase contrast images and HO334 labeling patterns as we increase the light dose. Here we see paraptosis, 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 but now we're starting to see apoptosis and necrosis, where the cells entirely fill with the HO334 probe. And so this is an example of what can happen at very high light doses where paraptosis is impaired. This slide looks at the potential for PDT involving paraptosis. Head and neck tumor cells from patients with a papillomavirus infection tend to be resistant to treatment with ionizing radiation. This is shown by the graph on the upper left. It's interesting to note that when we treat these cell types with photodynamic therapy, we see the opposite effect. The HPV plus cells are more responsive to photodynamic therapy, but the HPV minus cells are less responsive. The HPV minus cells tend to have an impaired apoptotic pathway, but these can be killed by paraptosis involving ER photodamage. We still don't know why the HPV negative cells don't respond well to PDT regardless of the target. This is not because the photosensitizers don't enter the cells. Singlet oxygen is being formed upon radiation, but the cells are poorly responsive. In clinical studies, these tumors still respond to vascular shutdown associated with PDT, but there's no direct cell photokilling. While studies in cell culture are important, it's still important to use animal tumors to determine whether or not there are other factors, such as vascular shutdown and immunologic effects, we just won't see in cell culture. It's clear that formulation procedures can direct targeting, which can promote the efficacy of photodynamic therapy. So when we treat animal tumors with PDT, we see effects that can't be duplicated in vitro. The effect on the tumor vasculature and the enhanced immunorecognition. This is an image shown of the great effect on the tumor vasculature by photodynamic therapy. This was image collected by Dr. Hassan at the Wellman Institute for Photomedicine, and we see that a very significant shutdown of the tumor vasculature occurs as soon as the light is turned on. This statement by Darwin does sum up our experience with photodynamic therapy. Once we identify the problem, we can set about solving them. So to sum up, in addition to identifying photosensitizers, it's important to explore targeting and cell death modes to produce the maximum anti-tumor effect. So we see apoptosis after ER lysosomal or mitochondrial photodynamic therapy enhanced by this combination. ER photodamage can also initiate apoptosis, and this is very important when we're treating cells that often occur in tumors that have an impaired apoptotic pathway. Autophagy is cytoprotective, but shares some pathways with apoptosis, as we've seen. The PDT efficacy therefore depends on the cell phenotype, and subcellular targeting is very important for maximum PDT efficacy. The potential for cancer control. We can treat tumor at surgical margins, where surgery does not remove the entire tumor. We have very high specificity for tumor versus adjoining normal tissue. Hassan's group and others are exploring the idea of using PDT in combination with chemotherapy, which I won't touch on here. And we have apoptosis, an additional pathway that can kill cells with an impaired apoptotic response. These are some of the people that are involved in this work. This is the group at Wayne State University. This is the group in Tayyaba Hassan's group in Boston. And this is an image from the sets for the Harry Potter films showing the Hogwarts castle in the daytime. And periodically they dim the lights and a collection of little lights start moving around in this castle. It's a very spooky effect. So if there are any questions, I can try to answer them and see if there's additional thoughts on the efficacy of photodynamic therapy and how it can be improved.